but due to some technical problems, we'll speak about only one topic. The way to 1,000 cases of transapical aortic valve implantation. This topic was performed by Dr. Claudio Grossi, one of my supervisors in MD thesis, and by me, Mohammed Shafiq. Next, please. At first, we have to discuss what's meant by transapical aortic valve implantation. And I insisted that it's transapical aortic valve implantation, not transapical aortic valve replacement, because we don't excite the native valve. We do only implantation of the valve over the valve. And so this procedure may be called sometimes valve over valve or valve on valve procedures. It's a progression in the cardiac surgery. Within the last decades, transcaster aortic valve implantation has come from relative obscurity to become a procedure that is practiced at most major health centers worldwide. Next. It may be done by transfemoral approach, transfemoral retrograde, and transapical antegrade approach were the most widely practiced. Transapical is the preferred procedure where the peripheral access, and this is my opinion as a cardiac surgeon, it's a preferred procedure where the peripheral access is limited due to size, calcification, toxicity, while transfemoral procedure more stable platform for transapical due to more direct, transapical more direct and shorter distance to the native aortic valve than the transfemoral approach. Access via the subclavian artery and the ascending aorta are emerging to be a viable alternative. We know that the incidence of the valvular heart disease in Europe is increasing, and it's expected next, okay? It's expected that in the 2050, over the 12 million people will be suffering in Europe, and the main valve disease is mitral. And then the incidence will be for the aortic valve. Next. Okay. Up to now, there's no strict guidelines for which patient should be considered. Actually, there's many problems confronting any surgeon or any cardiac staff surgeon teams regarding the transapical or transfemoral approach for the aortic valve replacement. These problems are which patient, what the indication, which route, transapical or transfemoral, what is the evidence-based medicine for the transapical or transfemoral aortic valve replacement results. Is it comparable to the conventional surgery result or not? Now we will speak about which patient should be considered. Okay, is next. According to the update of the American Heart Association and the American College of Cardiology guidelines for management of patients with valvular heart disease, this is last update in March 2014, it's recommended for transapical aortic valve replacement is recommended in patients who meet an indication for aortic valve replacement with low or intermediate surgical risk. Also, for patients in whom transapical aortic valve replacement or high risk is being considered, members of the heart valve team should be collaborate to provide optimal procedures. Also, transapical aortic valve replacement is recommended in patients who meet an indication for aortic valve replacement, for conventional aortic valve replacement for aortic stenosis with prohibitive surgical procedures and predicted post TAVI survival more than 12 months. There's some other indication for TAVI, but up to now there's no, even with this guidelines, no strict guidelines is mandated or is done all over the world. Okay, but what's meant by the high-risk patient of with aortic stenosis? Is it the age, the high risk? It is as a comorbidity. What meant by high-risk patient? Okay. We know that according to the thoracic surgery, Society of the Thoracic Surgery and Neuroschool, and previously, aortic valve replacement, we have two options: aortic valve replacement or medication for cases of severe aortic stenosis with high risk score according to the Society of the Thoracic Surgeon, or according to the Euro score, according to the Cleveland score, according to the Barcelona score, other score. But nowadays, we have to define the high risk score, and you have to define which patient is eligible for transapical aortic valve replacement to make a borderline between the patient operable and the patient who are inoperable. Next. Nowadays, TAVI is the gray zone between conventional aortic valve replacement and the medication for severe inoperable patients. Next. One example of the high-risk patient which is difficult to be operated by conventional aortic valve surgery, either conventional or minimal invasive, is the porcelain aorta, a case in which we can't touch the aorta because a minute touch for aorta will lead to a stroke and death for the patient. Definition of an operable patient means that the risk of the operation is more than the probability of benefit. And some surgeons say that I know an operable patient when I see it. Who are the high-risk patients with aortic stenosis? Octogenarian with the multiple comorbidities, the COPD, diabetes mellitus, low ejection fraction, or previous cardiac surgery. Patient with the previous myocardial infarction with the other graft, or radiation chest wall heart disease, or patient with the chest wall deformities, patient with lung disease, liver, portal hypertension, child's classification B or C, porcelain aorta, real indication degenerative neurocognitive dysfunction, real indication, and the stroke is also can occur in the TAVI. And high frailty index. What's meant by high frailty index? Next. Frailty. It's a biological syndrome of decreased reserve and resistance to stressors resulting from cumulative declines across multiple physiological systems and causing vulnerability to adverse outcome. Requires 3 of the following 5 characteristics. More than 5% weight loss in the last 1 year. Exhaustion measured by the Center for Epidemiological Study Depression Scales, decreased walk time, decreased physical activity, and weakness, measured by physiotherapist as dynamanometer. Okay. As the frailty index increase, it will lead to more risk patient. The 35% probability of death within 6 months. And 45% probability of death within 1 year. Okay. This is the diagram showing you what's meant by frailty. Chronic malnutrition, aging, weight loss, chronic inflammation, and illness lead to sarcopenia. Sarcopenia means osteopenia, decreased strength, decreased insulin sensitivity, and this is the frailty cycle or circle, as a vicious circle. As the chronic malnutrition will lead to sarcopenia, and this lead to decreased metabolic rate, decreased appetite, and more chronic malnutrition. Next. But we have to ask ourselves before doing that, if there is an overestimation of mortality for conventional aortic valve replacement, and so we revised our patient in Cuneo from January 2003, next sample please, from January 2003 to December 2008. Our patient age was ranging, the mean age for our patient was 69.4, and the overall mortality for our patient was 1.4. And then, next one. And then we are subgrouping for patients less than 70 years. The mean age was 58.8, and mortality was 1.1. Again, mortality for patients less than 70 years was 1.1. Next. It was surprising that for patient aging age range between 70 and 80 years, the mortality was 1.5 only for patients from 260. And so there's no significant difference between those patients having age range less than 70 and those having more than 70. Next. And those patients over 80 years, mortality was 2.1. Two patients only from 95%. And so the mortality, we didn't find that the age isn't a determining factor for concerning or for determining patient is eligible for TAVI or for conventional aortic valve surgery. Those patients having Euroscore logistic 7.1 plus or minus 18.3. Okay, next. Okay. TAVI needs a thoughtful surgeon, a cardiologist. Surgeon act as a gatekeeper or goalkeeper. And so this is difficult to be done here in Egypt. Okay. Also, TAVI needs a good operating theater, bypass capability, high quality imaging with high definitional fluoroscopy, transvaginal echo, surgical capability as a standby perfusionist, standby surgeon, sterile environment, and a good and a highly skilled anesthesia team. TAVI equipment, our study was done by Sabine Edward valve, transapical valve. We have two only size, 23 millimeter and 26 millimeter. 23 for aortic annulus ranging between 18 to 22 millimeter, and the 26 size of 26 for patient having annulus between 21 and 25 millimeter. And this is measured previously, preoperatively, to determine the needed size for TAVI and for our procedure. Okay. This is the delivery system. It's called a chamber system for placement of the TAVI. In short, for our juniors and those who don't know how to do TAVI, TAVI is performed by anterior thoracotomy, which is done about 3 centimeters. The site of the preferable, we have to determine the preferred site for thoracotomy by echo, by fluoroscopy. And then you opened on the 5th or 6th intercostal spaces. I prefer to open in the 6th intercostal space because you will be in line with the aortic valve more if you open in this space. And then you have to retract the, you open the pleura. Sometimes you need to do one lung ventilation, but actually we don't need it in majority of the cases. And then retraction suture for the pericardium. Open the pericardium cautiously because sometimes the Achilles heel for the TAVI, the major bleeding can occur while opening the pericardium, especially in the cases with the previous irradiation or previous cardiac surgery. And this is the system. You have to put two burst string sutures around the apex. I don't prefer to do the burst string suture in the true apex because sometimes it leads to apical rupture, and so you do it near the true apex, and then you enter the TAVI by caster. You need at first cardiologist to do transfemoral catheterization by the big tail 7 French or 9 French according to the size of the femoral artery, and then you deliver the valve by the delivery system. You need the crember. The crember here in Arabic called what's called the kasha. Crember to mount in the valve over the balloon. You have to balloon the valve at first, the native valve at first, and then you have to put the valve over the valve, and so you have to crimp the valve by the crember, and then you have to inflate it inside the patient. This is a Chandra system, a Chandra introducer sheet, inflational balloon, and this balloon will take about 20 centimeter volume, And this delivery system with a tri-seal hemostatic valve in the introducer sheath. Okay, the next. Again. Cuneo TAVI experience, we planned about 60 patients for TAVI, but the actual implant aborted in 60 patients, and the vascular access was very small, unsuccessful balloon aortic valvoplasty, and one case of active endocarditis. And so the only 54 patients were implanted, successful implant in 52 patients, and with 23 millimeter, about 25 patients, and 27 patients were implanted by the 26 millimeter Sabin valve. Implant failure occurred in the 2 cases for ventricular embolization and aortic embolization. This is demographic data. Female constitute 55% of patients. 86% of patients with hypertensive, carotid artery disease in 34% of patients, and the Euro score here is 25.8 plus or minus 15. I think this is a high logistic Euro score in our study. Okay. Procedure time minutes from the skin to closure of the skin, it's 135.9 minutes. Deployment time take 30 minutes. Fluoroscopy time 28 minutes. Contrast volume, and this may be hazardous for the patient, especially in those geriatric patients, 210. Reballooning, because sometimes we see that the site of the valve isn't good, and so we have to reballoon the valve, deflate and reballoon in 11% of the patient. Arrhythmia requiring intervention, I think, for some injury to the membranous septum during deployment of the valve occur in 60 patients. Okay. Regarding the pre and post-operative transvalvular gradient, echocardiographic evaluation, we see that the transvalvular gradient pre-operatively was a 45 point plus or minus 22, and this decreased after successful deployment of the valve to 10 plus or minus 4 millimeter mercury. Next. And this Kaplan-Meier score, 6 months survival, only 6 months survival, 90%, okay? 90% of the cases were freed from this at 6 months. Next. Okay. About the early mortality, 2 cases died within, 2 cases died after 30 days. Due to myocardial infarction, 1 for sepsis. Early mortality occurred in 3 cases within 30 days, and 1 case died due to cardiac arrhythmia. As we have said before, that a valve isn't implanted in this patient, and another patient also weren't implanted for infective endocarditis, with only 1 patient died in the 229 days after procedures for unknown cause. About the complication, myocardial infarction occur intra-procedure in 1 cases, and in 2 cases after 30 days. Stroke, renal failure, arrhythmia requiring intervention, new pacemaker, need for new pacemaker, cardiogenic shock also occur in 1 case during intra-procedure. Congestive heart failure occur after 30 days in 1 patient. And valve embolization, as we have said before, in 2 patients. Follow-up echocardiographic data, aortic valve area or annulus increased from 0.79 pre-operatively to 2.12 post-operatively, and the gradient is reduced from 45.6 to 10.3, and the ejection fraction also increased to a significant value from 52 to 54. Okay, now we'll speak about TAVI and the future. What about the perivalvular leakage, which can occur in these cases? And the second thing, that it's a bioprosthesis. And so what about the durability? Okay, next. What about the durability of these valves? And this another slide for complications which have emerged during the TAVI procedures. Valve malposition, implantation location occurring suboptimal. This is very difficult. Vascular complications, permanent pacemaker, perivalvular regurgitation. Only those patients with perivalvular regurgitation more than or equal to would be significant, but if there is less than or equal to, it will be insignificant, as sometimes it will be disappear after TAVI. Which valve? The next question is which valve to be used, Edward or Core valve? And so in the study, we didn't find any significant events between the Edwards or Core valve, as the other slides will be seeing us. Okay, next. Regarding the preoperative transvalvular gradient reduction, in some studies it's reduced from 44 to 8 by Core valve, and by Edward 45, and in our study to 10. Next. There's multiple trials by the others made by trial study for Core valve and Edward, and so we didn't find significant changes or significant change between the Edward and the Core valve regarding the perivalvular or aortic regurgitation post-implantation. Okay, next. Also, 30-day mortality, no significance between 30-day mortality between Core valve and the Edwards valves. Okay. Procedural complication also, no adverse outcome or no change between the Core valve and the Edwards valves. About the midterm survival, no. By safety and efficacy trial, which is formed by the Core valve, it was 78% at 6 months. At 32 months, it was 68%. And another by 18 French registry, it was 79% at 6 months. This regarding the Core valve midterm survival. And for the Edward valve, okay. For Edward valve, it was 83.4 at 6 months. And at 12 months it was 83. That is for Edwards valve's revive trial or revival trial. We can't say certainly that TAVI is the best alternative to conventional aortic valve replacement. Why? Early clinical trials reflecting frequent changes in the technology, procedural methods, and data collection. Also, study endpoint not clarified, and even in these trials, which I have previously described, study endpoint not clarified or standardized. Inconsistent use of data coordinating a center without coordination of the centers, and the poor long-term follow-up. As we see that the follow-up for these studies was ranging between 6 months to 1 year to 2 years. Okay. Thanks for you, and sorry for elongation.
Thank you.